Hi, everyone. My name is Lisa Solomon, and I will be your host today. So, I'd like to welcome you on behalf of the UCSD Parkinson and Other Movement Disorder Center to our second webinar of the year, Perspectives on Corticobasal Degeneration and Progressive Supranuclear Palsy, with our presenter today, Dr. Irene Litban, who is our center director and world-renowned movement disorder specialist. So I just have a couple of housekeeping things to go through, and then we'll get started.
Hi, how are you? How are things going? Hopefully everything is okay. Let me make sure this is working.
Looks good.
Looks good.
Mhm.
Beautiful. All right, so today we'll talk about interdisciplinary perspectives on atypical Parkinsonism. And as an example, we're going to use corticobasal degeneration and progressive supranuclear palsy. But I thought I should bring up also something about multiple system atrophy, although I will not talk specifically on that disorder. So first of all, what is an interdisciplinary perspective? Well, that means that you have what we call interdisciplinary team. In the case of us at UCSD, we have a beautiful team. You may know several of us that provide the clinical care. You may know some of you, our neurosurgeons. We have a new one that is Professor Arjun Kama. And we have a whole list of managers as well as coordinators of our research center. We have a lot of administrators as well as clinical coordinators. Actually, it's only one, but still very powerful, and that is Lisa, you know. We have fellows that are two clinical fellows, as well as scholars that are people from other countries who come to be trained in the United States. We have a group of neuropsychologists, and we have as well a group of rehab, that is physical therapists, occupational therapists, as well as speech therapists. You may know some of them. Why do we call this interdisciplinary? Well, we call it interdisciplinary because we come from different ends. And what I think is relevant is that each of us has a different view of what are the needs of you. And what we want to do is a personalized approach to medicine, approach that would try to comprehensively treat all your problems. And some of you may have problems speaking, and some of you may have problems walking, and or problems moving in bed, or whatever it is, or feeling that your memory is not as good, or that you want to participate in research, or that you want to know who are the people who come and see you in addition to all the physicians that you may know. So we want to welcome you from our own center. This is all the people that are working with you. Maybe you may see somebody that is not there, but the majority should be there. And this is particularly the group of clinicians, neurologists, neurosurgeons, nurse practitioner, neuropsychologists, and social worker. I don't know if you know, but we have a new nurse that is David Medina, who is phenomenal as well. We have this as a rehab team. We have this group as clinical coordinators for research and clinical coordinator, as well as administrators. This is our our current movement disorder fellows. These are the movement disorder fellows as well as the research international scholars. So what is our mission and our vision? We want to dedicate ourselves to provide the best diagnostic, therapeutic, palliative, and supportive care to patients with movement disorders and neurodegenerative diseases. We use cutting-edge technology to treat all our patients. What is our mission? To translate innovative research into state-of-the-art, comprehensive, personalized patient care in movement disorders. And what is our vision? To enhance mind and body one life at a time through new science, new medicine, and new cures. So what do we do? Well, we provide clinical care that is state-of-the-art. We provide the latest clinical trials, some to slow disease progression, as well as some to improve symptoms. We do clinical and basic research, and you'll see some of that later on. We do community outreach, and actually this is one of our community outreach efforts. We do the education to the community, as well as education to our fellows and research scholars. So we have a dedicated nurse practitioner that is specialized in movement disorders. Many of you may know her, and that is Kathy Wynn. She's phenomenal. Everybody loves her. We have a comprehensive deep brain stimulation program, a neurophysiology movement disorder program, and that is a program that is very unusual in pretty much any center in the world. That is a program that tries to improve the diagnosis of tremors and differentiate the different types of tremors, myoclonus, and different things that people may have because they have different treatments. We meet all as a group on a weekly basis. We review the deep brain stimulation patients that want to go into having that approach, or those that want to have a pump. And we also do our challenging patients and any other issues that may be brought up. We also have a pediatrics movement disorder program that is headed by Jennifer Friedman, one of the best movement disorder pediatrics that is in the country, and I would say one of the best in the world as well, who is at Rady's Children's Hospital. We offer an evaluation and management that is personalized, evidence-based medical and rehabilitative services to the patients as well as to caregivers. We do neuropsych evaluations, pharmacological therapies, Botox treatment for dystonia, drooling, eyelid apraxia. We do surgical interventions, as I mentioned, social worker services, urological services, and ENT services. And that means that we are united with a group of people that we work and are specialized in movement disorders. So let's give you an example. What does it mean that we do personalized and evidence-based medical and rehabilitative services to our patients and caregivers? So I want to give you a history as an example. It could be progressive history of falls, that is something common in people that have atypical Parkinsonian disorders, such as a progressive supranuclear palsy, corticobasal degeneration, as well as multiple system atrophy, as well as lack of medication benefit. That is a characteristic of this disease, although in multiple system atrophy, a third of the patients do respond to levodopa. And I would like to give you some guidelines that may help you to do a better visit when you come to see your physician, wherever you go. I think it would be very helpful for you to write each problem as it appears. Whenever you see that there is a problem, try to write down when that occurs, or try to think when it occurred. And a way to think about it is, let's think in an event. For example, let's think it was an anniversary, it was a birthday, it was a delivery of a baby, whatever it is. That helps you to think how you were at the time that the problem started for the first time. And then ideally, once they occur, you can continue to write everything that happens thereafter. Again, if you don't remember exactly, you can do the same. Think about any event in your life that is meaningful. You need to bring all your medications or write them down with the time of taking each medication. You need to, prior to your visit, bring, or better to send, all your neurological records, including genetic studies, biomarkers, if you have them, like alpha-synuclein, tau, amyloid, as well as bringing to your visit, or again, sending them, a CD with your brain imaging. For us, it's not worthwhile to see a report only. We see things that maybe a radiologist doesn't see because they're not experts in our field. I think it would be worthwhile to write down your questions. So when you leave, you don't say, oops, I forgot to ask that question or that other question. You need to have clear what are your three main problems. So that means that whenever you come to a physician, usually they ask you, so what is it that you want to resolve? What are your main problems that you want to resolve? If you're falling, obviously it's falls. If you cannot move a hand, it is that you cannot move a hand. If you cannot see well, the same. So whatever it is, you need to decide and bring it as a problem. And you need to bring in or send or write down in the computer all your completed questionnaires that you receive. So, what does a nurse do once you come to the visit? They will look at your weight, your blood pressure, your temperature, your respiratory rate. They would ask you about allergies and what are the medications, and they may look at all your medications, as well as we may do the same again when you see the movement disorder specialist. What do we do? Well, the first thing we ask is, what are your main problems? Then we ask you, okay, now tell me, what was the first problem you ever had and when did that occur? If you don't know exactly, approximately, was it 3 years, 5 years, 10 years? And that is very relevant because that would allow us to know if the illness that you have started at that time. And this is particularly relevant for the typical Parkinsonian disorders. Why? Because how they start and how they evolve allow us to make a real diagnosis. It is very relevant to know the second, third problem, fourth problems, whatever. So we keep asking, so what else? What else? What else happened? And when did that happen? Because that gives us like a gestalt, an idea of what is the diagnosis already when we're doing the history. Of course, we will ask you what are the other problems that you have from a medical and surgical point of view. We would ask you, do you have a family history of something similar or any other neurodegenerative disease? We would go over your current medications, not only what you take, but also how do you respond to that medication and when did you start taking it? Again, everything is approximate. Even if you could know by calling your pharmacy or looking at your medications. But I think that calling your pharmacy would allow you, or just thinking about, again, the first time that you can link it to an event. So we're going to ask what is the medication that you took before that may not be, has been not helpful. So what do we do as specialists in addition to doing all the history? By now, we already have an idea where we want to go. We do a complete neurological evaluation. That is, we look at what we call the cranial nerves, how you move your eyes, how you close your eyes, etc. And then we do a movement disorder evaluation. That is, we look if you have tremors, if you're slow, if you're stiff, how do you walk, etc. Then we are recording everything in your evaluation. We also look at your laboratory and imaging evaluations, including all your biomarkers, everything that you have brought. So then we can come up with a diagnosis. You don't have labs or imaging, that's okay. We come up with a tentative diagnosis, perhaps, or we come with an as good as we can come with a clinical diagnosis. And then we propose a treatment for you. So the diagnosis is truly based on what you tell us. There is no way we can see in your eyes what is your diagnosis. We need to know all your problems. That is key. If you can do that, you're going to really have a great visit. And this is good for your first visit as well as for your last visit, because things happen since you saw us before and now. And if you can tell us what happens in between and how did you respond to this medication or that medication, that is very worthwhile, because then we can give you a more specific treatments or a different treatment, whatever it is. So how do these patients with corticobasal degeneration and progressive supranuclear present? Well, they present in many different ways. They may lose the balance and falls. That is a very common evaluation, symptom, particularly for patients with progressive supranuclear palsy. You may have changes in your gait, being more unstable, but particularly the person that may have more changes in the gait, if the problems start in lower extremities, is the person that has corticobasal degeneration or corticobasal syndrome. That is what we call the way of presentation when the symptoms occur only on one side of the body. In general, these symptoms don't respond to levodopa therapy. So unless you have freezing, that is like getting stuck to the floor when walking, that may respond to the treatment with levodopa, there is no way that that treatment will improve your balance. For that, we have other treatments, and I'll tell you later about that. So, is there any other presentation? Yes, we have several others. There could be changes in your personality and present with apathy, not really doing as much as you used to enjoy the things that you like. That is not necessarily being depressed. It's not that you feel blue. You just don't enjoy the things that used to be very relevant for you, your hobbies, things that made you really very excited. And you may do things if they tell you, you don't want to go to the movies, but maybe they tell you, do you want to go to the movies? Okay, I'll go. And that means you don't really come up with that idea because it's not something that you think you're going to enjoy, but certainly you can do it. You may have some cognitive changes. And what do we mean by that? We mean that you may have what we call executive function. What is an executive function? It's a function of an executive. So it is a function in which you plan, in which you multitask, and do many different problems in sequence, and you can really allow yourself to be very creative and more having more ideas that are like concepts, not being so concrete in life. So that is what it is to be having problems with executive function. It may well be that you may not remember spontaneously something, but if they give you a clue, you will remember. That is different than what happens in Alzheimer's disease. In Alzheimer's disease, you cannot remember because you did not learn. And they can give you as many clues as possible, but you're not going to know because you never learned the information. For example, somebody may have called your wife when your wife was out shopping, and she comes back and she doesn't say anything, and you don't remember to say spontaneously, your friend so and so called you. But then she asks, did anybody call me? And then you say, oh yeah, it was so and so that called you. So spontaneously you cannot remember, but you remember if somebody asks you a question specifically. What other presentation? Well, you may have blurred vision when you're reading. You may have difficulty moving the eyes. I show you, and it is in the website, exactly what a supranuclear palsy is, a difficulty moving the eyes. You can see, but it is difficult to move quickly your eyes up and down, for example. And that means that you're going to have problems when you're reading, and particularly because what happens is the rapid movements of the eye, of the eyeball, not the eye per se, but the eyeball, then you cannot really follow lines. You may have problems opening or closing your eyes. The eye may close alone, or you may have a lot of difficulty, blepharospasm, in opening your eyes. That, by the way, that is treated with Botox as well. You may have a staring gaze, like because you don't blink much, you may have that. And that is all very typical of progressive supranuclear palsy. It may occur later on in corticobasal degeneration, but it doesn't occur initially at all. The apraxia, the difficulty starting a movement, it is typical of what happens in corticobasal degeneration. You may also have problems with a slow speech, a slurred speech, a decrease in the volume of your speech. You may have difficulty finding words, and your speech becomes very, very short in your sentences. So you really don't talk a lot spontaneously because it is like difficult to come up with the words. You understand perfectly well, but the words don't come to your mind. But it's beyond the executive function. That goes much, much more because it affects your spontaneous speech. That is not a problem of an executive dysfunction. So how do we manage a patient that has all these problems? By the way, I did forget to mention that patients with the corticobasal degeneration, I did mention that had problems in one side, and that is true. But in addition, they may have problems with dystonia, like the hand gets with an unusual posture. They may have what we call an alien limb, that is feeling that your arm or leg is not your own, and that may have movements on their own, or they may have little jumps, that is the myoclonus. Again, all this is in last year presentation, but I wanted to give you a different presentation today. So how do we manage? Well, we manage with a multidisciplinary team approach, and that's why we have the interdisciplinary team. It's the same thing to say interdisciplinary than multidisciplinary, by the way, because that is the only way to give you a comprehensive and personalized approach. That is, if you have problems with walking, we need to ask a physical therapy to help you. You may need only a cane, or you may need a walker, and you don't need an aluminum walker. Those aluminum walkers would make you fall with the walker. You need a walker that has weight, a weighted walker, like the U-step. And you need to learn how to use it. And if you have, for example, freezing, there is a light that, a laser light that is on the floor that allows you to step over and helps you overcome that problem. Well, you may have swallowing problems, and so maybe there is only a way, the only thing that you need is to move your head in a different position, or you may need thickeners to be able to swallow liquids without problems. The problems in movement disorders is with liquids, not with solids. You may have the problems with the speech that I mentioned. And there is several techniques that the speech therapists would use. And depending on the problem, there could be different ways of resolving that problem. There is the occupational therapy that may help you with computer, with transfers. There is also supportive therapy and education, because you need to learn about your disease. We learn about how is a TV before buying it, but we don't learn about the diseases we have and what is it that we need to do to improve them. And that is extremely relevant. You have in our team also a social worker that may help you with understanding when is it that you may have Medicaid or Medicare. That is not when you are 65, but when your disease is significantly impaired. But there are many other problems. We talked about problems that are urinary, that you may have urgency to urinate or inability to urinate. And we don't know that in men. In women, it's so much easier. But in men, we usually send them to a urologist who is giving the medications. And as I mentioned, we have a very good one. We give you treatment that is pharmacologic for all the what we call Parkinsonian symptoms. Parkinsonism is the presence of slowness, rigidity, tremor, or the presence of postural instability. But because the postural instability doesn't improve, I put that slowness, which is truly necessary for Parkinsonism to exist, and is improved by levodopa as one of the symptoms. So again, is the slowness and rigidity the symptoms that truly improve. At times, the tremor is a tremor at rest when you're doing nothing, when you're watching TV, for example. We mentioned the myoclonus that may occur particularly in corticobasal degeneration, and that is like a jump of your limb. And we have medications for that. We have medications if you have very low blood pressure. That does not occur in progressive supranuclear palsy or corticobasal degeneration, but does occur in multiple system atrophy. In fact, it's one of the first problems. So you're maybe, not necessarily, but in general is that when you get up, your blood pressure drops. That can also happen due to medications. That's why we review medications. And we give you non-pharmacologic or pharmacological therapies to resolve that problem. Non-pharmacologic, for example, is to put salt and to drink more water. Pharmacologic would be medications per se. You may have the difficulty in blinking, and so we tell you, oh, natural tears is very helpful. Or you may say, well, I see all blur, and that means that you cannot accommodate the eyes in the right position. And so we send you to an ophthalmologist that at times you may improve with prisms, not always. If you have dystonia, if you have blepharospasm, Botox can help. And if there are problems with mood, if you are depressed or anxious, antidepressants do work well. So we will also offer research, because being a center of excellence means that not only we provide state-of-the-art care, but also means that we provide you the possibilities of trying to advance science in the diseases that you have. And particularly, we're looking for markers to diagnose so much earlier corticobasal degeneration, PSP, dementia with Lewy bodies, and we have programs for that. And this not only searches for markers to diagnose it earlier, but also markers that can allow us to follow the disease when, for example, we give a therapeutic agent, we give a medication, and we want to see, well, this is what we need to see, that this marker decreases or increases depending what the problem is. That is not in PSP and CBD, but nowadays we have that in Parkinson's disease, that is alpha-synuclein, that we can look at in the skin, and we can look it up in the spinal fluid. There are possibilities of searching for some tau measures, but it's not yet replicated for more than one lab. And that's why we need to be able to say that this is truly a biomarker. We do evaluate treatments to slow down the disease, to prevent disease is what we would love to do, but it's much harder. For that, we did in the past some epidemiologic studies looking at different occupations. But at this time, we're going to start what it is called a trial for PSP. That is to provide different possibilities of medications that can be given to one person. And there could be 4 possibilities. 3 medications that do different things, of course, and what we call a placebo, something that can allow us to check if the medications do or don't do anything. So a person, instead of having the usual, that is either the medication or a placebo, here there is 4 possibilities. 3 medications and a placebo, and that's a new way of doing trials that is called a platform trial. We do have several trials for MSA. I'll go quickly over them. And we did have studies with antibody therapies for PSP, but those at this moment we don't have. There may be others coming up. We are also evaluation devices to better manage, for example, falls or the blood pressure, and I'll show you that. That's what we call the fall meter. We are also having devices to measure levodopa in case that you respond to that, but that's not what I'll discuss today. So this fall meter consists on smart shoes that have a platform and allows to record exactly where you walk and how you walk, so we can diagnose and treat it more appropriately. Would allow us also to know when you are unstable and fall. And we would see that, as you see here with this patient, because we put some markers that are very simple, that don't look as complicated as what you see there. And we are using caretaker to measure the blood pressure. We're using a device to look at the electrocardiogram, because what we want to do is to continuously measure blood pressure, gait, electrocardiogram, to be able to understand what is the cause of falls, because what it may happen is that a person may fall for different reasons, and we need to figure it out. Most people get to the emergency room and they don't know why they fall. They only know they fell. And this would allow us to better understand without having to admit a person into intensive care, that most of the times you may leave out of there not having a heart problem and being unable to figure out the cause, what causes that. We also have a cell phone that has different functions that allows you to tell us, and we made the same questions that we do clinically. Did you fall? Did you feel that you were going to faint? Did you? So we are asked several questions. And obviously, if you're not doing well, we say call 911. But we have several questions to ask if that is not a problem. And we put all that together, and that allows us to know when the person falls and look at the problems that happened before. And what we're trying to figure out is what are the patterns that would allow us to say, this is the main cause, and also prevent in the future a fall, being able to let you know, hey, don't get up because your blood pressure is too low now. So you need to say, well, give me some olives and some water, and I'll feel better. So we're gonna be treating the freezing gait with different forms of vibration. And these are studies that we do have now, and that we are trying to get pilot data. So that means few amount of data, so we can request a grant to the National Institutes of Health. So these studies, you can participate at the present time. The studies are done in the clinic now, but the ideal scenario is to go at home. We're also measuring the blood pressure with a new device that is being tested. I think that I may not have put that, so I'm going back because I thought I had some markers. So I mentioned that we have studies of biomarkers to try to figure out what are the markers And we did some MRI studies. Those are completed now, and apparently are very good to differentiate these diseases. But again, this requires more evaluations. There is several studies, 2 of them actually, that look with specific techniques, biopsies of the skin to try to differentiate PSP, MSA, corticobasal, etc. And there is a study in which we are looking at understanding the end-of-life care preference in different people that have different disorders, so we could provide a better care. There are several studies, as you can see here, that do look for treatments to slow disease progression or to treat the low blood pressure. And there is one that is already recruiting patients, one that the study already recruited, so I'm not going to be talking, but this one is treatment for the blood pressure. And the next one that is going to come is to slow the disease progression, and that is with a small molecules that inhibit the aggregation of the protein that deposits into the brain. These are our research facilities. Some of you may know them. This is how separated we are, but the areas are not so disparate. So where we do a neuropsychology testing in one place, we do the research studies, and most of us are sitting in the ACTRI, that is close to Thornton Hospital. And there is in Thornton Pavilion, that is almost across the street, where the rehab clinic is. We do have several centers of excellence for Parkinson's, but also for dementia with Lewy bodies. We have a research center of excellence. We have a center of excellence for MSA. And we have what exists, that is a center of care for cure PSP, that is for PSP and MSA. And we have several grants for the NIH and one of the Department of Defense. We have several collaborators within UCSD to try to advance science and advance treatments and understanding these diseases, as well as collaborators with many other universities across the country. That the most important one that we collaborate with is UC San Francisco, but certainly we collaborate with University of Southern California, NIH, University of Toronto, Veteran Administration, Case Western, UCLA, Cleveland Clinic, and Duke. And we have been in the news. We have been in the news because there was a grant that the Michael J. Fox Foundation gave us to have as an international academic medical center a movement disorder specialist that will do 1 year of clinical care and 1 year of research. And we have selected one that is doing the first year. Then I had the pleasure of being one of the 8 researchers among the best 1,000 female scientists in the world, and I shared that with several other scientists at UCSD. And thank you. Now I'm ready for all your questions. Thank you very much.